Hello. This feels so unnecessary for this room, but can everybody hear me okay? Wonderful. Thanks everyone for coming. We are presenting today on our overdose prevention and aftercare in Central City Concern Supportive Housing Program. My name is Juliana DePietro. I use she and her pronouns, and I am CCC's Overdose Prevention Program Manager.
And I'm Gordon Keepers, he, him pronouns, and I'm the Associate Director of Integrated Behavioral Health and Housing at Central City Concern.
So here's a quick overview of our agenda for today. We're going to cover some terminology, why we're saying the things we're saying, do a bit about our project, give a little background of what led us to create the model that we'll go into depth on in talking about care coordination, about the model itself. We'll share some preliminary data we've seen, as well as some lessons learned and next steps. So in terms of terminology, we like to just ground any presentation that we do in some word suggestions, some language suggestions. We at Central City really focus heavily on person-centered care, and so a lot of what you see on the right side, on the consider using side of this table, you'll notice that we have people first. So as we talk about people who use drugs, we're going to ask, instead of saying addicts, junkies, language that we might hear perhaps in the media, we're going to refer to folks as people who use drugs or people with substance use disorder. We never want to speak for anybody who refers to themselves in a certain way, but if I'm talking about somebody else, I'm going to use the phrase people who use drugs. We're also going to talk a lot about the overdose reversal medication naloxone, commonly known as Narcan. It's one of the largest brand names available, made by Emergent Bio. Naloxone is the generic formulation for that medication. So just a point of clarity, if you hear us saying naloxone, it's the same thing as Narcan, just using not a brand specific word. Also thinking about how we refer to folks who might be in abstinence-based programming or housing where urinalyses or UAs take place. So instead of saying clean or dirty UAs, we like to say positive or negative, really taking some of that more judgmental language out of the mix. Same goes for people. Again, not going to tell people what they should call themselves, but if I'm referring to somebody who has a period of sobriety or a return to use, I will say people in recovery or people who use drugs rather than somebody who is clean or somebody who is dirty. You want to cover the last two?
So medication assisted treatment is like commonly like Suboxone, methadone, drugs like that. There's a push to, instead of be calling it MAT or medication assisted treatment, we're calling that medication for opioid use disorder, so specifying what it's actually for, or medication supported recovery. And one of the important differentiations there is actually like drugs like Suboxone they're gaining more and more use in recovery environments. And so we want to kind of call out that people can still be in recovery and be on medication. Like, these are medications that support recovery. They're not a substitution for a drug that somebody was using before. And then the other one is when we're talking about people who are having a mental health problem, I encourage people to just describe the behavior instead of saying something like, that person's crazy or they're insane. You just say, that person is really agitated and yelling at me, or they seem really scared right now. And you can always say, like, this is a person with if you know that they have a mental health problem or a mental illness, person with a mental health problem or person living with a mental illness is more person-centered, more kind way to talk about them.
Just a quick overview for those of you who may not be familiar with our organization. Central City Concern is a large not-for-profit organization with campuses in downtown Old Town Portland as well as in East Portland. Our primary focuses of services are in housing, healthcare, and employment. And so I know this is a housing conference, so I'm not going to get into any of our clinical or job services data specifically in this slide, and really thinking about the amount of housing that we operate. So in 2022, we operated 30 properties that provided 2,286 homes to 4,542 residents across our continuum. So when we talk about this intervention, this clinical coordination, care coordination intervention in Central City Concern housing, this is the context that we're talking in. And just in a little bit more depth about what our supportive housing model looks like. We have a few different types of housing modalities. We have recovery housing, which is specifically for people who are choosing to be abstinent from substances or working towards that goal, designing housing to support people in their chemical dependency treatment and early recovery efforts. So those are folks who might just be exiting withdrawal management or detox programming. There's embedded case management in those buildings, and it's very focused on abstinence from chemical dependency and drugs. Other low barrier housing options that we offer, those goals might be present for folks there, but we're not going to require somebody to stop using drugs before they enter those spaces. It's more thinking about stabilization, meeting people where they need to be in their use journey with immediate accessible housing. We have transitional housing across both of these modalities where folks aren't permanently housed in their building. Again, it's really a place to stabilize either in their substance use journey or in other behavioral health journeys or otherwise until they can move into permanent, more independent housing. And that's also what we offer in terms of our permanent housing. We provide a significant amount of permanent affordable housing for folks who may need an added layer of assistance. So most of those buildings also have resident services coordinators and support systems in place, but it is kind of the most independent part of the housing that we offer, and it's long-term. So now we're going to talk about opioid overdoses. As we know, we are in an opioid overdose crisis in this city, in our county, and in our country as a whole. And our clients, our residents, are profoundly impacted by the rise in those overdose deaths in our state and in our community. Over the period of 2019 to 2021, so really as during the onset of the pandemic, we saw a significant increase in fatal and non-fatal overdoses across our continuums of care at Central City Concern, and particularly within our housing portfolio. As you can see on this pie chart, just in last fiscal year alone, 80% of reported overdose incidents happened either inside our housing buildings or just outside of our housing buildings, which is pretty profound. So our housing context is a really key part of this work, particularly thinking about the additional vulnerabilities that people have when they are using drugs behind closed doors. Overdose risk increases in isolated settings, which housing can be one, and particularly within the COVID pandemic, when we are asking folks to stay in their rooms, to not engage with anybody else, there's a higher risk for people to use, to overdose, and then to pass away because nobody knew they were using and nobody was checking in on them. A lot of affordable low barrier housing are single occupancy units, which mean that people are living alone, and especially if there are rules around visitors, guests, if it's transitional housing, participants going into each other's rooms, that isolation just increases. So one thing that we really prioritized at CCC was providing low barrier and accessible naloxone in all of our housing buildings. So at this point, every single one of our housing buildings across our portfolio of 30 has naloxone on every single floor so that residents can access naloxone, not behind a locked box, but really just in an open unit that is labeled that says overdose emergency. They can run, get it, and help respond to overdoses, and so can our staff. To that end, we wanted to make sure that we are providing comprehensive training for all of our housing staff teams in how to recognize and respond to an opioid overdose and also to administer naloxone. And we've seen preliminarily a decrease in fatal overdoses as well as an increase in the amount of times that staff are responding to overdoses in housing and using naloxone. So this is a really important component and really set the stage well for our multi-pronged approach to overdose prevention for housing and also for our organization as a whole. And I'm going to hand it off to Gordon to talk in depth about another prong of that approach.
Yeah, so once this was kind of identified as like a real big problem happening in our agency, especially in housing, one of the prongs of our intervention was to develop what started out as like a high-risk huddle model, and what ended up kind of morphing into like a harm reduction intervention and like a clinical care coordination intervention, and I will tell you kind of why. So a high-risk huddle model is like, you know, this person here, this one right there, that person is like a client that maybe has a problem. Maybe they had an overdose. Maybe we're worried they're going to have an overdose. So then we somehow identify that, and that there's something that needs to happen as an intervention to help take care of them, protect them. So then like Central City gets involved and we have like a huddle, right? So we actually literally come together as quickly as we can. We make decisions about what sort of levers to pull and what interventions to try to help protect that person. So those could be like, does this person need like primary care or to see a different type of doctor? Do they need wound care? Do they need some type of medication intervention? Or do they need to go to the hospital or to withdrawal management, something like that? So the problem with that is like, what if they don't want any of those things? Then you're kind of sunk. Like there's something really missing in this equation, which is why we pivoted over to both like an initial harm reduction intervention in the housing, and then like a clinical care coordination model, which looks more like this. So we have a client, maybe with a problem. Then we have somebody who's really skilled in engagement, really skilled in harm reduction intervention, and can really join with the client and understand what's going on for them. So this is our overdose prevention aftercare specialist. Yeah. Overdose prevention aftercare specialist. That's the title of the role. So they can talk with this person and they can understand maybe there's something going on that we need to understand. They can do some assessment. They can provide some information in that kind of initial stage. They can provide some stage appropriate intervention and harm reduction intervention, which is really important. Stage appropriate intervention is really necessary, I think, really when we're working with any clients, but especially with clients for high risk of overdose, because if we're deciding what they need and they don't want that, or they're not ready for that, or whatever, they're not going to do it. And then we don't have an intervention at all. So we can provide a stage appropriate harm reduction intervention, and that's like make sure they have access to naloxone, make sure that they know how to use it, make sure that they can have a way to use where they're not using alone, make sure that they have the right materials that they need in order to keep themselves safe and healthy. So then we have like the assessment, we've given the information, we've done some harm reduction work, and then we can understand maybe they do really want to be on Suboxone. Maybe they want to go to withdrawal management. Maybe they would like to see a doctor, but they would actually like to see a doctor that looks more like they do. And we would understand that by talking with them and having some assessment around that. Maybe they want some wound care. We can do all those things at Central City Concern. These are all things that we do all the time. But the difference here is that it like puts the client at the center of this intervention. And when we are, that previous slide that I showed you, the center of that intervention really was like us, like Central City Concern was very much the center of that high risk huddle. And that is something that we don't want. We want the clients to be at the center of this because that's the most important. So that's why we went with like a clinical care coordination model versus a high risk huddle. I wanted to talk a little bit about care coordination and like what it is. The takeaway is that nobody can really decide what it is. It's like a lot of things. This is like gets us kind of close to a definition of care coordination. So it's deliberate organization of patient care activities between two or more participants. Ideally, it includes the patient. Included or involved in a patient's care to facilitate the appropriate delivery of healthcare services. Organizing care involves the marshaling of personnel and other resources needed to carry out all required patient care activities and is often managed by the exchange of information among participants responsible for different aspects of care. So how about that for a definition? In a nutshell, that means like we're talking to each other. If I am in their primary care office, I should probably be talking to their like SUD counselor, their substance use treatment counselor. I should probably be talking to their mental health care provider. We should be knowing what each kind of separate care entity is doing so that we're doing the right things ourselves and so that we're not stepping on each other's toes and so we're not kind of like contradicting the care that we're giving to the client. So this still actually is a definition that is very, very, very non-client centered. Like this is all about the care organization or the care environment. What we are finding, so my job is like my job is all around the integration of like behavioral health interventions in housing services at Central City Concern. And so we are really finding in those kinds of settings that like care coordination actually really needs to include housing provider and supportive housing providers. And I probably don't need to tell you all why that is, but when I tell other people why that is, what I say is, well, like people who are where our clients live see everything basically first. So like in my programs, when we're situated in the housing, we're the first people to see somebody who has an overdose or is at high risk of overdose or has a return to use. We might be the first people to see that they're having mental health struggles, that maybe their medications aren't working as well as they used to, or they maybe stopped taking them. So this is all to say that like we have a really good pathway at Central City Concern now for two-way communication or all-way communication between housing, health services, supportive housing, and that's new. Like that's something that there's been historically quite a bit of like nervousness around because of privacy and HIPAA. And we actually have really good reassurance that if you're doing it in the right way and you're doing it for the right reasons, actually, you're on very good ground for care coordination because you're avoiding really harmful events and you're doing kind of the best you can to keep your residents and clients as safe as possible. So the other piece is that for these really high risk and vulnerable and complicated clients, we really need to have a clinical assessment around what needs to be addressed, what needs to be coordinated around, and kind of the interventions that need to take place. So this is like a little bit of a model. It's a little fuzzy. I'm sorry for that. But essentially, like this shows you like how this could all work, right? We do these like care conferences with like multiple entities all the time. Generally, it doesn't actually include a housing provider. So we need to be including housing providers. We need to be including housing staff and their wisdom and their experience with these clients. And that would include like a resident service coordinator, case manager, even potentially property management has a seat at this table, I think. And we need to have it be like multi-directional communication, right? I like a really fluid kind of like feedback loop where we can get really quick information in lots of different directions. So to illustrate kind of like who we built this program for, this is a sort of a clinical vignette to kind of demonstrate just how complicated and nuanced this can get and why we need some clinical insight and assessment around this. So this could be a very, very typical overdose prevention and aftercare client. Brenda is a 33-year-old Black African-American cisgender woman who's living at a CCC housing location. She was referred to OPA by an assistant case manager because they had overheard her talking on the phone with a friend. Brenda had told her friend that she was having a romantic relationship with a man who's been providing fentanyl to her and encouraging her to use it. She describes the relationship as feeling scary and sometimes violent, and that she sometimes uses fentanyl with him even though she doesn't want to. She's open to meeting with an OPAs, but when meeting with her, she appears anxious, irritable, and she frequently looks over her shoulder and reacts to nearby noises and intensely. So this is a question that we ask people when we're interviewing for this position. And the reason is teams, the tyranny of teams, it never goes away. The reason is that like, it's like, what would you do? This is like so complicated. It's not as straightforward. I think that historically in this organization, what we might have done would be to reflexively, refer this person to a detox center, to Hooper or something like that. I'm not so sure that that's the right intervention here. I think that there's actually probably several interventions here. And these are the kinds of assessments that we're doing with this program on a day-to-day basis. We assess around mental health complexity, need for medication, substance use, behavior, risky use, intervening around that, readiness for things like medication-supported recovery. So there's a lot of assessment that goes into this before we kind of really understand the full picture, and we can make kind of informed plans around what we're going to do to join with this client and intervene. We look at a lot of things, including readiness and like all this clinical information. I think we got. There we go. So I want to talk about the model.
Just make sure I didn't.
Oh yeah, actually, I thought I was missing a slide. Okay, so what we landed on here was like a blended model that is based on it's a few things. So I have experience with a program through OHSU called New Directions in C-Train, and that is a transitional care program, outreach-based, works with street homeless folks, very, very complicated and vulnerable folks, with a lot of this kind of like that last slide I showed you, similar picture to that. So that's like assertive engagement-based, kind of rapid intervention, transitional in nature. So the goal is to get, know this client, know where they're at, understand what the needs are, and then like get in there and start making this stuff happen. In addition to that, there's some existing models for these like post-overdose response teams or PORT programs. And those are also based around this like rapid response. So 24 to 72 hours from referral to first engagement is really important. And then rapport and trust building as the focus of those first outreaches. So, and that's something that we found actually is really vitally important, because the engagement is actually one of the hardest parts in this program. Cold call engagement with clients in this kind of situation is really challenging. And when we're hiring for this, we're prioritizing, one of the skills we're really prioritizing for is engagement skill. So like we want somebody who has exceptional ability to like gain rapport and trust very, very quickly, because they might have like 5 minutes with a client the first time they meet them, and they need to be able to see the client again, okay? We also decided that tangible harm reduction interventions were really the most important thing at the very beginning, besides this trust and rapport building. So when we get that trust and rapport, we get the engagement with the client, then we can start offering things. And the most important things to offer are the things that are going to get the people the most safe the quickest. So that's all harm reduction. That's, do you have access to naloxone? Do you know how to use it? Do your neighbors know how to use it? Do we have enough of it in the building? Do you have a safe way to use if you're going to continue using? Do you understand what increases your risk of overdose actually? So there's a lot of harm reduction interventions that we can choose from, and it's really very client determined, but like that's like the next thing that we're doing in this intervention. And then what we're doing is that more complicated assessment in the following interventions. As we're building more trust, we're understanding what's going on with the client, and we've established some safety so that we can make sure that they stay alive for the next time that we see them.
So this model, this overdose prevention and aftercare program and team, has been operational for almost 4 months now. We launched in early June and started taking referrals. When Gordon and I put this slide deck together, we had gotten 22 referrals in 4 months. We've gotten, I think, 6 or 7 in the past week. So think about that number being a little bit higher. And we've had some really cool early successes within this program. I might hand it back to you for just some anecdotes that we've had. I want to just walk through these charts a little bit. So when we talk about referral disposition, it means we got the referral, what happened with that person. What we've seen is that about a third of the people referred to our program, we were able to enroll in the full breadth of the program, which is a 90-day intervention for all of the things that Gordon mentioned. But about 2/3 of folks we were actually unable to enroll. And on the chart on the right, the reasons for non-enrollment are primarily that we were unable to contact folks. So as Gordon mentioned, that early engagement is such a critical component of this work. And even when we have folks who are in housing where we think we know where to find them, we know what door to knock on, they don't answer the door, we can't do much. So unfortunately, about 2/3 of folks are unable to contact. But with the folks we have referred, we have fully enrolled, we've been able to make contact. We've seen some great care coordination successes. Are there any you want to talk about?
Yeah, I think there's, my favorite one is just because of how many sort of the interventions that we did were really cool and kind of like novel. And then this client actually touched a lot of different systems at CCC, which is kind of what this program was built for. So we had a client who is involved with one of my other programs called the Community Engagement Program, and was referred to OPA after he had a return to use of fentanyl. He was housed at one of our permanent supportive housing buildings, and he was having trouble in his housing. And part of it was because he had returned to use. So he enrolled in the program during this kind of troubled period where he was actively using. The housing specialist of the community engagement program had worked out an arrangement so that he could vacate his unit, return to our transitional housing at the Golden West without getting evicted. And in the meantime, he actually went to withdrawal management at Hooper to kind of come off of the fentanyl as comfortably as possible and engage in abstinence-based recovery again. So he did that successfully, went back to the Golden West. Our OPA's nurse, Mei Lee, started actively engaging with him. This guy is like one of those people who is just like, you know, he'll take like really all of the engagement that he can possibly get. So he's a great client. He's doing really well. He had another return to use about probably a month later. And he had used so much fentanyl in the previous 5 or 6 days that he had run out and he was withdrawing painfully and really rapidly. And he was in such painful withdrawal during the most recent heat wave that we had that he couldn't leave his room. And he was, throwing up. He felt absolutely sick. He was weak, dehydrated, just doing really, really awful, and not accepting emergency medical care. So, and it's not something, as probably people know, you can really force on somebody. So harm reduction, what we did was we had Meili, our OPAs, outreaching to him on a daily basis, bringing him food and water, doing some very, very light nursing assessment for him, making sure that he was able to intake fluids and food, and then kind of gauging readiness for different things. And once Meili was able to understand that he was open to reinitiating on Suboxone, then we had like a real kind of task at hand, because normally if you want to get on Suboxone, you got to go to the clinic, and this guy wasn't going to any clinic. So couldn't leave his room, be very protective for him to get back on that medication. There we go, get back on that medication. And what we did was we have a kind of like ace up our sleeve where we have some real medical expertise on the substance use treatment side, and we called our substance our SUD medical director, Amanda Risser, and they were able to work on the phone together, Maylee and Amanda Risser, to assess that it was safe and appropriate for him to get restarted on Suboxone. She called in that prescription, and Maylee went and picked it up for him and brought it back, provided some education around how to reinitiate on it. He also got a sleeping medication so he could get some better sleep, and left him after having reinitiated on Suboxone and ready to get a good night of sleep. And he's been on like an upward trajectory ever since then. He's actually most recently, after all of this, is started on Sublocade, which is an injectable form of Suboxone, which is a long-acting form, which is even much more protective than like the oral form. So like pretty novel intervention there. It's not something that I'm aware of us having done in this agency before. And I think truly actually could have saved this guy's life.
So what are some lessons that we've learned so far? We found that, as Gordon's anecdote just outlined, this type of care coordination intervention that's really client-centered, client-driven, and in deep partnership with housing providers and staff provides critical opportunities to connect residents to the medication, the services, and the support that they need. Building bridges between different providers, yes, within our really large agency that has a lot of those resources already, but also to external agencies. And providing that care coordination allows us to support folks on the housing side, on the outpatient treatment side, in really connecting and talking with each other, all in service to this client, to this resident, and what they need. To that end, we are working towards and have really found the need to build stronger connections between our resident services team and our clinical care teams, who see different parts of the client needs in very, very different contexts. And to some of what Gordon was saying earlier, don't often communicate, maybe because of HIPAA concerns, maybe because of other concerns, but sometimes fundamentally just because there's no relationship there. And so having a care coordination intervention allows us to build relationship across those service lines, and in service to really bridging those relationship gaps, so that we can, when we can step away, since this is a brief intervention, those relationships are strong and that care coordination can take place without us. Some of the pieces that we've learned within our housing context too, particularly within our recovery context, are just thinking about where our housing staff come from. We have a really unique and beautiful workforce pipeline at Central City Concern, where we support folks with lived experience with homelessness, people who use drugs, people who have complex behavioral health issues, in getting supported employment in our own agency. And so sometimes that looks like working within our housing context, never within the buildings they live in or have lived in, but folks will operate the front desk, be assistant case managers, and then become the framework and the foundation of our housing staff. And that is incredible, and also means that those staff have lived experience with overdose, with other types of behavioral health issues, both either personally or in their community, or both, such that even interventions like just having naloxone in the building can be really complex. And we want to make sure to offer the lesson of really listening to all stakeholders involved in launching really a novel intervention like this, and making sure that we are appropriately managing what can be a necessary and important, but sometimes difficult to understand change. And also just, thinking that as much education as we're providing to our participants around harm reduction, around safer practices, that we have a lot to learn from them as well. As much as we think about learning from each other as staff stakeholders, we want to keep our participants, our residents centered, recognize that they have a lot of strengths and that their goals are valid, and also driving the direction of our services based on their feedback and voice. Any other lessons you want to talk about?
I think when we look at some of our preliminary data, which is, our sample is low, but this blue no contact piece is something that we really are needing to focus on. And I think that the ingenuity piece of the intervention is probably the most important. So this number is too high, and we would like to really get it down. And in this kind of preliminary phase of this pilot, I think we've been surprised to see actually just how high that number was. And there's a lot of reasons for it. You know, some of this is, you know, our pilot sites are you know, 2 of them are like really abstinence-based recovery housing sites. And so we are trying to sort of shift a little bit the mindset of like, once you return to use, you're out. We're trying to put some pause there so that we can work to at least have some protection in there, because we're talking about clients' lives at this point, especially when it comes to fentanyl, where the overdose risk is so incredibly acute. And then even when people are ready to you know, ready to engage in like withdrawal management, the withdrawal is really painful, is the other thing that we're finding. So people are really having a hard time getting fully detox from fentanyl in particular. So yeah, I think that's the only thing I had to add. Is that it? So I think we have a lot of time for questions. These are our contact informations if you want to send us emails. But yeah, we'll just open it up for questions.
I ask this whenever I get a chance to interact with other folks across services and stuff at CCC. I work at CCC as well on the real estate development side. Do you ever see any difficulty with residents of CCC housing to get them to actually open up and engage with the clinical side of CCC? I've always been curious about just like the resident perspective of having your landlord also be your medical provider. And is there reluctance there, or do you just see the benefit? I imagine it could be cool.
Yeah, that's a great question. So the question essentially is like, what are we seeing in terms of this kind of having health services so integrated into your property management, your housing? Yeah, this is like literally is a huge part of my job. I think it depends. I think it certainly is client dependent. There are some clients who absolutely will just not, you know, they will not engage with the health services side of CCC because they are not comfortable with the proximity to their housing. And that's understandable, right? I mean, like one of the reasons that we are uneasy, and I mean like we as like a global uneasy about like sharing information like this, is that we don't want information to be used against clients to get them unhoused. I don't think anybody wants that. So we have to be really careful with how we share information, what we share, why we're sharing it, and how much. There's got to be good reason for it. As long as you have a good kind of understanding of why you're sharing it and why you're sharing what you're sharing, I think it's okay. We always ask for permission. We have a pretty like broad release of information at Central City Concern, which kind of just by its very nature includes housing, health services, and employment services. And then people can opt out of that. And even on top of that, I have my staff being careful about, you know, you don't release everything to everyone, right? You make sure that you're thinking about your audience. And so for the clients, I haven't seen it be like a big, it's not an overall issue. Like I wouldn't say it's the rule at all. Most of the clients in the programs that I'm over actually really appreciate and like the health services that are integrated on site. And that mostly comes down to trust. Once there's trust there, I think that people feel less uneasy about it. And then the thing that's an obvious benefit is just that it's like there. I mean, you know, some of the folks that engage with us at like one of my programs is a building called Cedar Commons. we got several folks there who probably wouldn't be seeing a mental health therapist if it wasn't just for the fact that they're seeing someone right downstairs. So I think it's overall, it's a good and welcome intervention. And then there are, of course, those circumstances where people can choose to opt out, and they should be able to. You have anything to add? Yeah.
Or do you give them options that they don't have to go on Suboxone, because I mean, if you take one drug to another drug, and then how does that reduce? Is there a method to injecting of the Suboxone that is used to take? Is that part of the plan, or you cut that eventually on the therapy, or how does that play out?
Yeah, thanks for that question. So thinking about offering medication to support recovery, I just full disclosure, I'm not a doctor. I am a harm reductionist and a public health expert. And truly, when we talk about coming at this work from a harm reduction perspective, we want our participants to lead in their goals. So we don't require anybody to initiate medication if that's not their goal. We don't require anybody to stop using if that's not their goal. What we offer is a broad spectrum of education about what the consequences of that use could look like, some options for using more safely, and as we build trust and relationship, getting at the root causes of what leads somebody to use in the first place, so that if they decide not to use, we really understand what supportive factors they need to provide protection against a return to use if that's not their goal. So if medication is part of that journey, we connect somebody to a physician who can provide a medication plan with that person. And a lot of those medications, they have different effects depending on the drug of choice, depending on somebody's body, their physiology, their tolerance. Again, not a doctor, but those medications don't create the same type of physiological high that opiates do. And so they're intended to support recovery in helping folks gradually transition off of opioids, or stay on that medication to support recovery as a protective factor, as one would like an antidepressant or an SSRI, for as long as they feel that that protection is necessary. So while that medication taper can be part of somebody's journey to recovery, sometimes it isn't. Sometimes somebody is on Suboxone, methadone, Sublocade, Subutex, whatever they choose, whatever their physician indicates, for the rest of their lives. And from the perspective of harm reduction, if that is what is clinically indicated for that person and that's what they want and need, absolutely. And truly, you mentioned therapy as well. I think having a comprehensive plan so that we're not just saying, here's some medication, that's enough. If somebody is willing to and interested in engaging in other behavioral health support wraparound, if they identify, yeah, I actually am continuing to use because it helps me deal with the effects of complex PTSD from my childhood, for example, perhaps some therapy would be helpful, some cognitive behavioral therapy, some dialectical cognitive behavioral therapy, dialectical behavioral therapy. Those could be indicated as part of somebody's plan. But really what I want to emphasize is that there are no contingencies from our approach. We don't say, you can only go on Suboxone if you have therapy, or you can only get therapy if you stop using drugs, right? It's going to be what the person wants, and then providing as much to care and resources that will support those goals. Does that answer your question? Correct. Yeah. Yes. You're already doing most of my tips. So you're very well set up. You've got the instincts are spot on there. Other pieces that I would advise are, and I think groups and posters really encourage this, but just encouraging open conversations about use, building trust with folks so that if they decide to use, you understand the prevalence of use in your building, that your staff community understands the prevalence of that use, not in a punitive way, but really to understand who might be using, how can we support them towards those goals. Encourage engagement in syringe exchange services for people in active use, because those can also be really supportive in building out harm reduction education-based services if you can't offer them within your building. And then I'm not sure, but depending on your resource constraints, there are also some really cool built-in interventions. There are these really amazing devices called Brave buttons that can be installed in buildings where if somebody's using and they're worried about overdosing, they can press a button and it'll alert somebody on the staff team to come check on them, right? So for buildings that don't have the resources staffing wise, that could be an interesting option to consider. And there's some great data out of San Francisco and out of some parts of Canada where those types of projects have been started. But yeah, I mean, fundamentally, it really sounds like you have the relationship trust building and destigmatizing lens that is the most critical in trying to provide these interventions. Anything to add?
Yeah, the only thing I'd add is that, like in our buildings, we're really seeing like the vast majority of reversals are being done by peers and neighbors. I'm sure it's the same for where you're at. And, anecdotally, what we've found to be really supportive and helpful is making sure that the people who have, the neighbor who has done a reversal is that we're taking care of them too. We're checking in with them and seeing how they're doing, and that we're also saying like, hey, thank you so much. You saved that person's life. And that's a really big deal. And that I think has generally been really meaningful to people. And it also creates a culture of like, we're going to take care of each other and we're not going to get people in trouble for doing it. We're going to this is where we're at. We're just trying to save people's lives and we're going to take care of each other for doing it. Yeah.
I have a question going back to the medication aspect. I think I speak for most of us that when I recognize that I need a medication for something, especially if I don't have care established somewhere, it's a lot of jumping through hoops, and it can take weeks to get in somewhere between going through your insurance, finding someone that has availability, establishing care, calling my insurance. It's a mess.
Mm-hmm.
I was wondering, for your clients that decide that they want medication, what does not only the timeline but the hoops look like that they have to jump through? How long when they decide they want it and when it's actually in their hands and ready to use?
Totally, yeah. So in our agency with our clients, what's kind of the time frame to when somebody decides they want to initiate on some type of medication, how long does it take realistically, and what are the hoops to jump through for those? That's what you're asking is actually kind of a big part of why this OPA program was developed. So our goal is basically immediate initiation of something like Suboxone if that's what somebody wants. And by immediate, my ultimate goal is actually same day. And I think we're actually, from a programmatic level, probably not there yet. I can't say that we could do that for every client every time, but we have done that for clients. And there's no reason why we can't, if that makes sense. So we have two clinics that provide medication-supported recovery. They primarily prescribe Suboxone. There are some other options too that aren't quite the same type of drug that Suboxone is. But we have one of those clinics at the Blackburn Center and one of them at the Old Town Clinic. And in theory, we can get them in for a walk-in the same day or the next day. And it might take a couple hours of say, in terms of hoops to jump through, the main one is just honestly paperwork. So you have to, if you're not registered with one of those clinics, you do have to register with them for primary care in order to get them medication. Our access department has done a really phenomenal job in the last year and a half of taking that intake packet for Old Town Clinic and Blackburn from being about this thick. I know from experience because I've filled it out with clients many, many times in my career. It was used to be about this thick, and it's about, I think it's about 15 pages now, which 15 pages still seems like it's long, but that's a huge, huge improvement, and it's a lot less paperwork to have to deal with. So that's the main hoop. We're also all sliding scale. So even if you didn't have a payer, if you didn't have insurance, we really kind of see patients in those clinics regardless of ability to pay. And if you come in and you don't have any money and you don't have any insurance, then you are at the bottom of the sliding scale. And that's kind of our model as an FQHC. So yeah, does that answer your question? I don't have data for you on that. It's something that we want to study, but I don't think we have high enough numbers of initiations yet to actually study that for our response. Totally, yeah. So what I would say is, like, depending on what buildings y'all are in or where you all work, getting a good understanding of which clinics provide these kinds of supports. Blackburn and Old Town Clinic are great for their medication-supported recovery. We have really great providers there. We can get people started really fast. The other thing to keep in mind is that there are a small handful of methadone clinics in the Portland area. And what we're seeing with fentanyl actually is a real push back towards methadone right now, which is a little bit counterintuitive and feels a little bit like, for me, like, because, really Suboxone kind of proved itself as a much preferable medication for this. What we're finding with fentanyl is that it's so strong that methadone is actually, in a lot of situations, more effective. So what I would say is, like, make sure that all of those options are available regardless of stigma. I think that methadone has some stigma attached to it, right? And I would say keep an open mind with methadone right now because it's kind of cutting edge, right, for the fentanyl use at this point. No, methadone is an older medication that is oral. It's either in a liquid or a pill form. It's very similar to Suboxone, but it tends to be a little more sedating. It's a little bit more active on the receptors, and it's a daily dose medication. Like most of the clinics that do it, you have to go to the clinic in the morning to dose on it. So it's been around for a long time. Suboxone is a lot newer. Suboxone has a long-acting form, which is one of the benefits. But yeah, methadone, we're seeing more and more use of it.
One that you guys can, I guess, get more easily, right? I mean, I know that in our organization, we have it on hand for overdoses, but do you teach them how to use it?
Yeah, so we have developed a curriculum for all of our employees so that if staff, because prior to this project coming online, we found that the majority of our staff, when they'd encounter an overdose, one, weren't sure if it was an overdose, and two, if they thought it was, didn't know what to do. And so that training is really critical. Having the naloxone is only as good as trained people to know how to use it. We have now incorporated that training into onboarding for all of our new employees at CCC and have prioritized our housing and supportive housing staff who are already here and making sure that they're trained as well. In terms of our residents, we're working on setting up a training program. There's early conversations with some outside agencies since we don't have the capacity to train all of our residents. Unfortunately, I wish we did. But in the meantime, we really encourage residents to get that training. There's amazing trainings online if they have internet access. There's some great fact sheets that have visuals that just walk folks through the steps. I'm working on seeing what kind of community-based trainings we could offer for organizations in terms of that capacity building, so keep in touch. Yeah, that is a great question. And I'm more than happy to stick around and talk to folks a little bit about recognizing and responding to an overdose. I want to make sure that we get. I saw another hand in the back, so let's stick around and let's chat about that. I can either do it via mic or just one-on-one with folks. I don't think we have numbers for you, but I think we can do best guesses if that's okay. Yeah, it's totally going to vary. So our largest site is one of our early recovery transitional housing buildings called the Richard Harris. They have 7 floors of units. I think their population is around 200 residents. That sounds right to you. And then they have 1 resident services coordinator. They have a couple like community building assistants and a community manager on the property management side. And then they've got an embedded early recovery housing case management team that has anywhere between 4 and 6 staff, depending kind of on the day with turnover, unfortunately. And we have 1 OPAS for not just that building, but for all 5 pilot sites. We're working on hiring a second one. So if y'all know any amazing clinicians who are interested, send them our way. And so the ratio tends to be that like we try to keep our OPAS ratio to their client caseload as 1 to 15, knowing that overdose prevalence in our building communities is going to be higher. And so part and parcel with that direct care intervention, given the infrastructure of staff layers and of resident layers that you're asking about, is really providing that. How do you recognize and respond to an overdose yourself? How do you recognize, especially in those early recovery programs, what are some of the warning signs that somebody might return to use, which after periods of not using can be a risk for overdose, right? Because tolerance is low. So how can we start to think about what overdose risks look like, even for folks who aren't using, and really do kind of a community spread of education to provide more protective support for folks when we can't have OPAs directly in those spaces. I think for like the OPA number doesn't change, but the staffing ratio changes across our pilot sites. Some of our smaller sites, I'm thinking about Cedar probably is the smallest. Do you have numbers or thoughts on that one?
Yeah, so Cedar Commons is probably is the smallest. It's so 60 units there, and the staffing is fairly robust. It's like I actually run a clinical mental health program there too. So that's 2 FTE of mental health clinician, and then there's 2 FTE of supportive housing. So there's a case manager and a peer. Each of those are full-time, and there is a actual full-time program supervisor as well in that program. So that's a pretty well-staffed program there. In addition to that, actually they have, I believe, 4 full-time positions for CBAs, and they have a property manager too. So a lot of staff. That building is it's one of our newest projects, and it runs pretty acute in terms of mental health, just because of our who we take in for referrals, who we prioritize for referrals. So it's a more acute building, which is why we have more staffing. Yeah. So how do we get buy-in from like kind of specifically from sort of the housing side as like sort of the clinical thing that's coming into housing, and like yeah, totally. I just rely on Juliana DiPietro to build run. No, it's a lot of relationship building, and a lot of trust building, and then like really level setting and again and again recognizing that we all have the same goal, which is to help keep our clients alive and keep them housed. But I think I'm not surprised you asked the question. It's one of the more challenging aspects of this. I think that we've had for all the work that we put into it, we've had some really, really good response from our partners in housing. I think that it's a really good sign for like future similar interventions.
I think the other piece that I'll add is just recognizing the ways that we can work together and how these interventions not only help keep clients safe and alive, but also can reduce some environmental and community issues within a building as a whole. This education, this intervention, this client engagement, and the types of engagement techniques we use really try to dig in to get clients a little bit more aware of the risk to themselves and also the risk to the community of their behavior, or at least the impact on community of their behavior, particularly when those behaviors are impacting their ability to stay housed. And so I would lean into, as talk about that relationship building with property managers, think about the impacts, the positive impacts of having an intervention like this, having naloxone, having some of these really life-saving measures can have on the building as a whole, building stability. And while, I think about at least just having the naloxone intervention in the building, at first it was a lot of work, and now naloxone wall mount box checks are just part of our regular community building assistant rounds, right? It's just integrated into every other safety check we already do. And so figuring out ways to integrate some of these key processes into protocols and procedures that already exist. Unfortunately, we have to normalize overdose response in communities of affordable housing, but that normalization means that, we're already doing a lot of the work and it's just adding maybe one box on a checklist.
It does help to be vertically integrated with property management, not looking at third-party property managers. I think that level of synergy at CCC being able to do.
I would very much agree with that. Yeah.
Other questions or thoughts? These have been really great. Appreciate y'all's engagement. All right, hearing none, I'm happy to stick around and chat with the folks who are interested in learning a little bit more about recognizing an overdose and communicating that information out. Otherwise, thanks so much for your time and attention, y'all.
Thank you.